everyone. Happy New Year, and thank you for joining us here at Strand Explains. My name is Sakshi Shingle, and as always, I'm joined by RK. So today we thought, hi RK, thanks for joining us.
Hello. Hello.
So today we thought we can continue on with our series on COVID vaccines and explain a little bit about the storage modalities, efficacies, what they mean, and why they're so important. So let's first maybe just jump into what storage modalities are. The way vaccine transport and storage works is once a vaccine is created, it needs to be kept at a specific temperature and in under certain conditions to ensure it's stable. So the temperature is to ensure that the vaccine doesn't denature. There are some vaccines can't be exposed to UV light or sunlight, and so having a storage modality and having a standard of practice in place is really important. Now, when it comes to vaccines, there are two main modalities. You can have a frozen modality and a refrigerator modality, and this is called the cold chain system, which you might have heard about in the recent past. So in the frozen cold chain system, um, any vaccine has to be kept between the temperatures of -50 and -15 degrees Celsius, whereas in a refrigerated storage modality, the vaccine has to be kept between anywhere between 2 degrees to 8 degrees Celsius, so slightly warmer, which is why it's a refrigerated storage modality. Now, beyond this, refrigerated vaccines are now being developed to allow for what is called a controlled temperature chain, where they can leave the 2 to 8 degrees Celsius cold chain for a limited amount of time and can be stored up to 40 degrees Celsius. But this is just before administration and cannot be done over a long period of time, so maybe 12 to 24 hours. So, RK, with that very brief explanation of storage modalities and the frozen versus refrigerator modality, could you maybe talk about the three vaccines that have been recently approved and what these storage modalities mean for them?
Yeah, that was perfect. Thanks, Sakshi. Yeah, so there's two storage modalities, right? So where do these three vaccines fit in? And the three I'm referring to are the ones that we discussed in the previous call too, the Moderna, the AZ, and the Pfizer, right? So the Moderna is an mRNA vaccine, and you look at the CDC website as an example, it actually gives you sort of, or it hints at a tier of possible storage, two tiers of possible storage modalities. The one that's actually listed says -15 to -25 Celsius. So that's pretty cold, right? And that fits into your cold chain storage modality. And it also says that vaccine vials can be stored between 2 and 8 degrees Celsius, which is a refrigerated storage modality, the second one that you just covered. Mm-hmm. And if you went on the Moderna website, they pretty much confirmed this. So basically, if you want to store it for a long period of time, like 6 months, then it's the -20 Celsius modality. And then if you want to store it for a shorter period of time, so maybe just before administration or for 30 days up to before administration, then you refrigerate it. It's 2 to 8 Celsius. And it also says, yeah.
Oh, sorry. Go ahead. So I was going to ask if you've pulled it out into that 2 to 8 degrees Celsius, can you refreeze it?
You can't, and that's actually explicitly mentioned in the CDC. Well, actually, that's on the Moderna website. It says that you can't actually go. You can't if it's thawed, then you can't refreeze it because then that denatures everything. So that's the deal with Moderna, right? Mm-hmm. So those are as far as the Moderna goes, mm-hmm. Right? And so these are pretty pretty cold. I mean, if you want to store it long term, then basically the takeaway is you store it real cold. And then, between up to 30 days, you can store it in a fridge. With the AZ, it's all fridge all the way. And this was always the case, right? The AZ Oxford vaccine. Mm-hmm. We always knew that it could be stored between 2 and 8 degrees Celsius. And that has a lot to do with the way, the mechanism of action, right? The platform, the vaccine platform, which we covered in the earlier podcast, right? It's an adenovirus vector. So it's not quite as sensitive to changes in temperature. I should say it's not quite as sensitive to temperature per se, but changes are different. All right. So 2 to 8 Celsius for the AZ vaccine. Mm-hmm. And I want to take some time out to talk about the Pfizer vaccine. That's why I put it at the end, right? Although it really belongs to that same category of mRNA platforms, right? Um, the Pfizer vaccine is really sort of, it exemplifies why this, in what ways is this pandemic and the response to it, how unprecedented it is, right? In many ways, right? So one way is it's an mRNA vaccine, and we've never had mRNA vaccines before, right? So
Yeah.
Moderna is also like that.
Mhm.
And before this, mRNA was regarded as a promise, but no one had really developed an mRNA vaccine.
Mhm.
The second thing that makes it unprecedented, right, and this has to do with storage, is it has to be stored within 10 Celsius of -70. So pretty much assume it's a -80 type deal,
Yeah.
right? And it has to be stored at that temperature,
Which
no matter what you do.
which we haven't seen before. And actually, I was about to
Yeah,
ask you about that. Is I mentioned that up to like if you look at the CDC website or the WHO website, all
yeah,
SOPs for cold chain only go up to -50 degrees with Celsius. So as recently as mid 2018, late 2018, all these SOPs only hit -50 degrees. But as we're seeing with the Pfizer vaccine, it's going to -80 degrees, and which is
absolutely.
mind-boggling.
Absolutely. And that's a perfect point. That's another reason why it's completely unprecedented. Everything, this entire the past 10 months
Mhm.
is that there haven't even been like SOPs on most of these websites for dealing with something that needs to be stored at such a low temperature.
Mhm.
Um, yeah, and that's a great point. Um, and the list keeps going on. There's this note on the Pfizer website about how there are thermal sensors on every shipment,
Mhm.
and if any shipment the temperature of every shipment is monitored, and if the temperature exceeds the limits, then that shipment is marked and possibly never used again, because of course you can't use a denatured vaccine and still expect protection. so
Yeah.
so
Yeah.
those are some, yeah, those are the three vaccines and where they stand as far as storage goes.
Thanks so much, okay. Like, yeah, it's so fascinating. Like you're saying, the number of changes we've seen and just advancements in technology and how things work over the last 8, 9 months is crazy. And I think one of the things that come up with this, like with the Pfizer vaccine, where they've had to create these GPS thermal sensors, like you're saying, is trying to figure out how possible it is for these different storage modalities and different cold chains to be set up in different countries, especially in places which are maybe more rural versus urban, which haven't
Yeah.
had to deal with these things. So maybe you could you maybe talk about just what the differences between these storage modalities are and how they'll affect countries in a very real way in terms of having the resources, both infrastructure and just people who are trained to uh, deal with these situations.
Absolutely, absolutely. That's a great point. So, really, what do storage conditions have to do with the rural-urban divide, or, the developed country versus developing country divide, right? I mean, I think it really speaks to that divide in a very explicit way as well. Is that, you know, it's very hard to ensure beyond any shade of doubt that this shipment never went above -70 Celsius. Never, never warmer than -70 at any point in time in its history, right? So for instance, you have to tag it with thermal sensors and whatnot, right? Now, this is not technology that is easily available or is cheap, as you can imagine, right? And and the reason it's expensive is because it kind of needs people that have the expertise and are trained to look at this uh, on a daily basis, and really, really like understand the cost of being wrong is very high, right? Because if an entire batch of vaccines is dead, then you can't really inject those with inject anyone with those vaccines. So uh, that's why, for instance, the Serum Institute uh, took the bet on manufacturing the AZ vaccines.
Mhm.
It's because you can store them in the fridge, and fridges are available. They are not new technology, and things can be transported between 2 and 8 degrees Celsius. And it was not going to be unsafe, and it was the right thing to do, perhaps for developing countries that have masses and masses of people that need to be vaccinated, a lot of whom are in the rural areas where you do have to have a strong logistics chain that can get you to the final point of care. um, and this is a thing in the US too. It's not as though I was talking to one of our clients the other day, and she was saying, look, the Pfizer vaccine is great, but it's not going to reach all of us,
Yeah.
even in the US. She was talking from Seattle, yeah, right? So uh, it's just you need both. You need both the Pfizer vaccine, and you need things like the AZ vaccine, which are
Mhm.
probably easier to transport, and that's just
Mhm.
the nature of it.
Yeah. No, that makes sense. And I guess talking about that, the next, like you said, the AZ was the Pfizer vaccine might not be available for everyone. And a question that has been coming up, I've been asked before is, oh, but the Pfizer, we might have to wait a little longer, but the Pfizer vaccine has a much better efficacy versus the AstraZeneca vaccine.
Yeah,
But no one really
yeah,
knows what that means, and no one really understands it.
yeah,
They're like, oh yeah,
yeah,
95% efficacy versus 70% efficacy. Why wouldn't I
yeah,
take that? So could you maybe talk a little bit about what efficacy is? Explain what those
yeah,
numbers really are? That could be
yeah,
great.
yeah. So the way efficacy is calculated is that you have two cohorts of people,
Mm-hmm.
right? And it can get complex, but the simple idea is just you have two cohorts of people. One of them is injected with the vaccine candidate,
Mm-hmm.
right? And the other one is injected with the placebo, right? So placebo just is no vaccine. It's just maybe saline solution or whatnot, right? And then these guys are monitored over a period of time, and the incidence of COVID in these two cohorts uh, is computed over some pre-specified amount of time, or based on some other condition, which I'll get to in a second.
Mm-hmm.
But the idea is that if you have sufficient numbers of people in either cohort, and if the number of people that develop COVID in the vaccine cohort is very small compared to the ones that develop COVID in the placebo cohort,
Mm-hmm.
then you have a vaccine that has a certain efficacy. So some numbers, for example, let's say you had 20,000 people in the vaccine and 20,000 people in the placebo cohort. You injected all of these guys with vaccine, placebo respectively. You monitored them over a period of time. 162 people developed COVID in the placebo cohort,
Mm-hmm.
and 8 people developed COVID in the vaccine cohort.
Mm-hmm.
Then you say that the vaccine has an efficacy of 162 over 170, which is about 95%,
Yeah.
right? And these are the numbers of the Pfizer vaccine, which was the first to come out.
Okay.
And their termination criteria wasn't time.
Mm-hmm.
They stopped the trial when 170 people had developed COVID in all arms combined, right?
Okay.
So they stopped it and then said, oh, okay, let's look at what the efficacy is. Then that was the condition imposed, I think, by the FDA way back when they started the trials, and
Mm-hmm.
and that's what they reported on. So this is what efficacy really means.
I see. Okay. So you're basically looking at from the people who have been vaccinated, from the people in the trial who have gotten COVID, how many of those were vaccinated versus how many of those were on the placebo? And like you're saying,
Correct.
for the Pfizer vaccine, 95% of the people who were vaccinated and had and got COVID, 95% were actually given the placebo and 5% were given were given
Correct.
the Pfizer vaccine. I see. And
Absolutely.
similarly, could you maybe talk about the AZ vaccine and what the AstraZeneca, sorry, Oxford vaccine, and what the numbers behind it are?
Yeah. So the idea is the same. The efficacy is computed in the same way, but the
Mm-hmm.
AZ vaccine is a little more complex because they had two different. Well, I mean, they had two different geographical cohorts.
Mm-hmm.
The intent was to have the same dosage for both cohorts. It was they were just one was in UK and the other one was in Brazil,
Yeah.
right? I think unfortunately one of those cohorts received a lower dose. So there are two doses in the AZ vaccine,
Mm-hmm.
right? You receive dose one at time one, time point one, and then dose two at time two, and that's when you're fully vaccinated,
Yeah.
right? So people receiving dose one in the Brazil cohort actually received a lower dose uh, than they were supposed to have,
Mm-hmm.
and for a reason that is still yet to be explained, they had a better response than their counterparts in the other cohort that received both standard doses.
I see.
And so I think the disparity was 90% versus 62%, right?
Mm-hmm.
So the 90% was LD, SD, low dose, standard dose, and 62% was the standard dose cohort, right? And if you do the weighted average between these, you get 70% efficacy, which is really what AstraZeneca is reporting their efficacy to be,
I see.
right? But it's really an average of these two different dosing regimens.
Mm-hmm.
Uh, but I mean, I believe that at the end of this, there will be one dosing regimen, and corresponding to that single dosing regimen, there will be an efficacy associated with that, right?
Okay.
So one has to remember that when thinking about the AZ vaccine efficacy.
I see. Okay, that makes sense. Thanks so much for explaining that. Okay. I think one thing that should also be maybe highlighted in this is when the race for the vaccines first came out and when people were trying to figure out, can we find something that can work, can be used to fight against COVID-19? Initially, the targets were 50% efficacy, with the hope that even if every other person can be protected against COVID-19, we'll hit herd immunity, and
Yeah,
we'll be able to protect our population at large against COVID-19. So
correct.
numbers of 70%, 95, obviously a 95% efficacy is incredible, but even a number of 70% efficacy is just as incredible and just as hope inspiring, at least to me.
Yeah,
So I think that's another thing just to remember for sure.
absolutely.
Mhm.
100%. So, or 70%. It's good. Yeah, yeah.
Yeah.
If you 70% of your population is protected, then you have herd immunity. This is
Exactly.
the case,
Yeah.
and usually these numbers, and you can always compare these numbers with other numbers like those for dengue and so on,
Hmm.
uh, and other vaccines. And these are actually very flattering. Even the low numbers are very flattering, and
Yeah.
they are remarkable, I should say, not flattering, but very are remarkable. And in such a short space of time, they definitely speak to how much our technology is developed in this. I mean, since sort of the early days of vaccine development.
Hmm. Yeah, no, that makes sense. I think another thing I wanted to ask you about is when calculating efficacy, how are the trials conducting if a patient has COVID versus they don't have COVID? Were they doing testing, or is there information on how that happened?
Yeah, that's a great question. So, the Pfizer trial had 41,000 or so
Mm-hmm.
volunteers. And now you can't really, I mean, it's very, very difficult to test these people for COVID after they receive the vaccine, because COVID is not a thing that you once got and can always be tested for. It's something that you keep needing to test for, right? And even if you just had to test for it once, that would still mean a lot of testing. So instead, what they did was they defined the end point in the trial not as people who were confirmed COVID by the RT-PCR test,
Mm-hmm.
but who were confirmed COVID by having at least one of the symptoms of COVID,
Mm-hmm.
after which they were administered the RT-PCR test for COVID,
I see.
right? So it's not that everyone was tested for COVID for the how many months the trial went on for, I think about 6 months or so. It was that the people that developed symptoms in either arm
Mm-hmm.
were then subsequently tested for COVID with the RT-PCR test. And if they tested positive, then that constituted a positive test result in either arm.
Okay.
And this is the case for all of the vaccines.
I see. Okay, that makes sense. So I guess what you can say about these vaccines then are we know that it's stopping symptomatic patients, which in itself again is a really big deal and is really, really cool.
Yes. But I guess the flip side of that, and there are many articles on this now already, which
Mm-hmm.
is that we still don't know, and the key word here is don't know, whether if you receive the vaccine, you can also be an asymptomatic carrier of COVID,
I
right?
see.
So, so we still don't know if, let's say, one receives the vaccine, one can go out without a mask, because while you are protected, it doesn't mean that at the same time you have no probability of infecting other people.
I see.
So you can still try, you may be still able to transmit the disease
Mm-hmm. But you
e-
yourself are protected.
even after you receive the vaccine, even although you may not experience any symptoms yourself.
Okay, I see. And so I guess the takeaway point for that is until we're told to, even with vaccination, please keep masks on, social distance as far as possible.
Absolutely,
Hmm. Stay safe, like they say.
100%.
Um, yeah, so I think
Yes.
uh, maybe we can pause, we can stop there for this session. Any other things you wanted to bring out or talk about, RK?
Um, Not at the moment. There's this new strain that's going around that made the news a few, you know,
Hmm.
weeks ago. I guess that the UK and South Africa detected first in the UK and South Africa, but also detected elsewhere.
Hmm.
Um, and questions about whether the vaccine works are circulating. I mean, so the vaccine works for all the strains, right? And this is a valid concern. I mean, it has to be addressed because with flu, for example, you have different strains of the flu, and you have vaccines for particular strains of the flu, but not a
Hmm.
universal one for all strains. But
Hmm.
unlike the flu, the this is a much simpler organism we're dealing with here, um, and the indications are that the vaccine will work on the new strain just as well. Each of the vaccines so far approved will work on the new strain as much as they will on all the other strains that have been circulating. But stay tuned on that because, and as we know more, we will talk about that on this podcast.
Yeah, thanks, RK. And to end on a slightly positive note, you mentioned that the flu is it's a more complex virus, and it's the common cold is common for a reason. But what they're seeing globally is number of colds are going down because all of us are masking and social distancing and sanitizing. So if nothing else, maybe we're just gonna flu season is gonna be a lot less, lot worse, lot sorry
Yeah,
not going to be as bad as it was
yeah,
um, a few years
yeah,
ago because we're slowly, get moving away from it as we stay sanitized and healthier. So that's nice to know. Uh,
absolutely,
yeah.
absolutely. Now,
Okay.
I think we've become a safer.
Oh, I,
I mean, I mean, even after this goes away, our mask habits might persist, and that's a good thing.
yeah, definitely. Yeah. I mean, I, I'm going to be very careful about washing my hands a lot more than I was, at least, if nothing else. But yeah, I think we can end there. Thanks so much, Arcade. It was really nice talking to you as always.
Likewise, always a pleasure.